Live? Okay.
Hello, everyone. Thank you for joining our Specialty Careers webinar series. My name is Adina. I'm the Specialty Careers webinar lead, and this is our webinar on internal medicine training. And Dr. Louis and Dr. Patil are going to share their experience on the interview, application and training in the IMT pathway. Thank you very much. I'm going to hand over to Dr. Louis to start presenting. Thank you.
Hi everyone, I'm Chantel. I'm an IMT2 at Maidstone Hospital. KP's an IMT1 who works with me. We're just going to give you guys a brief overview of the application and interview, and then we'll run through quickly what it's like to be an IMT as well. Next slide.
I'm doing that today.
Yeah, next slide as well.
So this is kind of the timeline of the dates for the 2025 applications. Oh, I just wanted to mention, if you have any questions, just pop them in the chat and we can go to all of them towards the end. So this is kind of the timeline of the application. So the application's open on 24th of November, and the closing date for applying is at 4 p.m. on the 21st of November.
Yeah.
Then this is after the applications close. This is followed by long listing. So this is basically when your application is compared to the criteria, just to check your eligibility. After that, there is shortlisting. So it basically just happens a day after, and you are generally invited to interviews around 19th to 23rd December. You must book your slot around this time, so around 23rd December. Make sure you book your slot early so you get the time of your choice, whatever is comfortable for you. The interviews are held for over a month, between 13th and 14th January. The rankings are generally released around mid-February, and late February in this case, and you get about 20 days or so for program preferencing. Just to be careful at the program preferencing stage, there are a huge number of programs to rank, so about 1,600 or so. So they take time. You have to go to each one, see what the specialties are, what your rotations are, and then rank them. So make sure you do that early and don't leave it to the end moment. You start receiving your offers around 18th of March. This will be followed by upgrading. You can hold or accept your offers at that time, and 4th April will be the deadline to accept the final offers, and the programs generally start on the first Wednesday in August. So we have just put this slide to show you that the competition ratio is kind of increasing. So it is becoming more and more competitive. We don't have the 2024 here, but I'm sure it is out. We can see the trend. It is the competition is rising. So make sure you definitely take it seriously, prepare your portfolio, and do the interview properly. So just to be eligible, you should hold the license to practice with the GMC. You should have completed the UK Foundation program, or you should have the CREST form signed if you are an IMG, or if you have dropped out of the foundation program and are coming back. So you need to be careful that you're just getting the CREST 2024 version signed, because that is the only one that is going to be valid for the application cycle. So this slide is about the experience that you should have. So if you are in a foundation program, you don't have to worry about anything. If you are in your F2 year, you can apply for the upcoming round and you will be eligible. But generally speaking, you should have 24 months experience after graduating from your medical school. If there are any IMGs, so you can count. So some countries do have things like internship, which are included in the medical school curriculum. So it is included in your program. You can count that internship, the 12-month internship, as 12 months to make it a part of the 24 months. That is the requirement. You should have the remaining 12 months after you are eligible or you have full registration. It does not have to be with the GMC, but with the counterpart in your country if you're an IMG. So moving on, over to you, Chantel, for portfolio scoring.
Great, thanks, KP. I think just a couple more points I wanted to add actually before I forget about the timeline. Just with regards to the ranking, like KP says, it's really, really overwhelming because obviously every single deanery is available and there's many, many jobs that are available in each deanery, in each hospital. Just have a look through the spreadsheet because different hospitals will do it differently. They should list which hospitals the tracks are at, and it should list which specialties are included in each rotation. But some places, for example, will do 2 6-month rotations, whereas other places do 3 4-month rotations. So it's really up to your personal preference and what you think works better for you. So for example, for KP and I, we both have 3 4-month rotations, but other trusts in London, for example, might do 2 6-month rotations instead. And also for some tracks, they will straight away tell you what rotations you have for IMT3. Other places don't tell you what you have for IMT3, and there's an element of choice there. So if there's something specifically you're interested in doing for your IMT3, that might be a beneficial thing for you. So just really, really have a quick, like a very careful read through that spreadsheet because it can be very, very overwhelming. I think the second point to make about offers, though, is that people who've done foundation before, you'll probably be familiar with this process, but you can, once they give you the offer in March, you can accept the offer straight away, or you can hold and wait for an upgrade, like KP mentioned. But the important thing to know is you need to be absolutely certain you're happy with your with your rankings, because if you opt into automatic upgrades and you change your mind and you've ranked something above the current job that you have, you could get upgraded into a job that you actually don't want anymore. So make sure you're very happy with your current ranking before you hold with upgrades, because I have seen people actually get upgraded into a job they no longer want. So just be very, very careful and make sure you're happy with your ranking before the deadline. So that's just couple other things to watch out for. But we'll go over some portfolio scoring now for the interview, and hopefully that will answer some questions. So just a point to make is that the portfolio scoring keeps changing year to year. So I applied 2 cycles ago and the point system has already changed quite a bit since then. So if you are not applying this cycle, please, please, please make sure you recheck the point system before you apply next year, because it might change again. So this is applicable only for this current application cycle. So the first section, the first domain that you can score in is postgraduate degrees. So please keep in mind that, unfortunately, they've taken away all intercalated degrees from the self-assessment. So you can no longer score for any intercalated degrees, unfortunately, that you've done in med school. If you have done an intercalated degree that is relevant, so for example, if you wanted to do cardiology and as part of your intercalated degree, you did a cardiology themed project and you got a publication out of it, although you won't score for it in your shortlist score, you should definitely mention this in your self-presentation during the interview. The second point to make about postgraduate degrees is that you cannot claim a teaching-related degree here and also in the teaching section as well. So you can only claim in one section. Next slide. The next domain you can score for is presentations and posters. The amount of points you get will depend on whether it's a poster or an oral presentation, and whether this is presented internationally, nationally, or locally. You need to evidence this, so you have to be able to provide a certificate. If it's a presentation that was accepted, you need an abstract to be uploaded. And if it's an oral presentation, you need to upload the slides. Or if it's a poster presentation, you need to upload a copy of the poster. If you are applying this cycle and you don't really have anything to score for in here, it's probably quite difficult to get a high scoring item at this point, unless you're presenting something, this month or next month, and you'll be able to upload the evidence by November. But this is a fairly easy thing to get good points in if you're applying next year. So even if you did, an oral presentation locally, that will give you, 2-3 points, depending on if it's an oral or a poster presentation. So if you're applying next year, this is a fairly easy section to get some points in. If you're applying this year, unless you've got something lined up right away, you might not be able to get huge numbers of points in this one. Next slide. Publications. So this is an area where you can get a lot of points, but the amount of points you get depends on whether this is original research, whether it's PubMed cited, whether you're first author. It's very easy to overclaim in this section, so be very careful and read the fine print because it's very specific what counts for top points and what is not. This is probably the most difficult section to score in if you don't already have a publication now, because publications can take, years to get sorted. So if you're thinking of applying for next cycle, I wouldn't necessarily waste your time trying to get, an original PubMed cited publication sorted out in, 8 months time, because you need to have a PubMed ID to prove by the time the next cycle rolls around if you wanted, the top 8 points in this section. So I wouldn't necessarily waste all of your time trying to get 8 points here. You might be able to get, a case report rolled out. But I think there's easier sections to score extra points in if you're applying for next cycle. Next slide. Teaching experience. So I think this is a fairly easy section to score points in. Again, the amount of points claimed depends on the time frame of the teaching and the level of your involvement. If you aren't applying the cycle, as long as you're regularly sending out feedback forms to med students and you're able to get a letter from a consultant confirming your involvement in teaching, saying, I provide bedside teaching, once a fortnight, once a week to, medical students at the hospital, then that's enough evidence and you can get a fairly easy 3 points here. If you're managing to organize and design a whole new teaching regime, then obviously you get the 5 points. But 1 to 3 points should be a fairly easy thing for you to sort. Even for this cycle, actually, you could probably get a letter and probably get some feedback forms ready for the next month. Next slide. Training and teaching is a separate domain related to teaching that you can also score points in. The easiest way to get 1 point is to do a Teach the Teacher course. This is usually an online course, 1 or 2 days. Usually if you're an F2 or if you're a clinical fellow, sometimes trusts will fund this for you as part of your study budget. Getting a PG cert or a PG dip in med ed is possible, but it can be very, very expensive and time consuming. If you're not applying this cycle and you're interested in education and you're going to take an F3 year or JCF year anyways to boost your portfolio, it's worth looking at education fellow jobs because sometimes trusts will fund a PG cert for you and then you don't have to shell out £5,000, I think is the cost of one. So you don't have to shell that out yourself and they might fund it for you. So worth looking into if you want to max out your points in this section and you're not applying this year. Next slide. The last bit you can score in is QIP. The amount of points you can score depends on how many cycles of a QIP project that you've performed and how much you were involved in this. Worth looking at the evidence you need to upload because it's called a QIPAT form. It's linked on the IMT recruitment page. And they suggest that that's the evidence that they need to show that you've been involved in a QIP project. You can also upload, if you've presented it, the poster presentation or the slides from a presentation, and you can also upload that as additional evidence. So those are all the domains that you can score in. And once you've put in all of the points on your self-assessment, based on these points, you then get shortlisted for an interview. And I think KP is going to talk us through the interview process now.
Yeah. Just some tips for the portfolio and shortlisting. As Chantel has already said, start working now, and if you are applying next year, then you have some more time to try and do other things that might take some time. One thing I would like to say is don't underscore yourself, but at the same time don't overclaim, because if you think that you're not sure what domain or what descriptor your achievement falls under, then it would be better to go with a higher one, because you can then justify in the interview. But yeah, that is about it. So moving on to the interview. So the interviews run for over a month, from mid-January to mid-February. They are conducted online using a system called Cupacom. It's a fairly decent system. It's easy to navigate. but make sure you check your equipment, have availability of a quiet room, and I'd recommend you use a headphone, because sometimes if the internet is not good or the speaker's not good, you can at least hear the questions properly, so that you're not answering something random. It's completely not related to the question. It takes about 40 to 50 minutes for the interview, so make sure you have that much time assigned for it, and book your slot early so that you get a preferred date. Talking about the format, there are 3 questions in the interview. The first one is your application and achievements. This was a question that was added from my cycle on. It's not really different to the generic question that you have on most job interviews. Take us through your CV. So it's basically the same thing, but you describe your CV more in the form of achievements for this application and how they are relevant to IMT. So if you have something like honors and distinction, like you would have talked about in your CV, I have this degree with honors, so you definitely should mention that. It is an achievement. You can talk about your QIP, your teaching experience, your leadership roles, MRCP if you have it. Yeah, that would be something that's an achievement at this stage, and so you should definitely talk about it. This 2-minute presentation is followed by some questions, so the interviewers might ask you to describe something in a bit more detail that is not clear, or just ask you some follow-up questions to talk about your experience doing a project or doing the QIP. What were your takeaway points, something like that. The reason we have marked 2 minutes as red is because you must stick to 2 minutes. At the end of 2 minutes, they will stop you and move on to questioning. So I think it is good to have like a closing statement to say that because of these achievements, I think I will make a good candidate or an excellent candidate for IMT. We all know that everybody is applying to get into some kind of specialty, and even the interviewers know. So it's okay to mention that you are interested in XYZ specialties, but at the same time, you want to broaden your experience by working in various medical specialties as part of your IMT. So yeah, it's a good idea to have a closing statement. I'd also recommend you time yourself and try to finish this section in about 1 minute 50 seconds, because sometimes it can take a bit longer when you're actually presenting it in front of the interviewers, so you have some time there. Right, so the next question is a clinical scenario. So it's a case that they'll give you a short statement. It's more of like an acute scenario, and you'd be expected to do the assessment of the patient, management, investigations, all those things. So these are some of the examples, but there can be any kind of acute scenario there. So hyperkalemia, decompensated liver disease, delirium, CAP, TB, pulmonary edema, etc. After the A2E does take time, so make sure you go through all of A2E thoroughly, because you will be provided further investigation. So if you don't ask for a chest X-ray, then it is difficult for the interviewers to just provide you with a chest X-ray. They will provide it to you, but it definitely does not look good if you do not request a chest X-ray in your A2E. So make sure you go through it thoroughly. This would be followed by some questions about the case and these are generally further management investigations. If it's a TB, then don't forget isolating the patient. COVID, again, isolating the patient. So these are small things that they look for. So that is important. At the end of your second question, you are given 1 minute to hand over this patient. So here you should follow the SBAR approach, and your handover should be precise and without unnecessary detail, because it should be 1 minute long. That is it. This is followed by the third question, which is based on your ethics. So it would be an ethical scenario. We're given the scenario, and you would be asked follow-up questions. So how would you approach this scenario? Whether it's the patient, it can be an angry relative, breaking bad news, drunk colleague, etc. So, and this will be followed by some questions. So that is it. These are the 3 questions of the interview. So yeah, would you like to add anything, Chantel?
Sorry.
Sure,
I can talk a bit about my interview experience. So I interviewed in 2022 while I was in F3. So I think the format of the interview was exactly the same as when you interviewed, KP. So we had the same 3 stations. I think I can talk a bit about best way to prepare it as well, or I think you've got that coming up on the slides as well.
Yeah, we'll get. I'll just put this here. Don't worry too much about this because you should just try and do the best you can. But it's good to have it at the back of your head. So you have 2 interviewers who score you out of 5 for each question, and then there is a weighting added, so that your score is multiplied by that weighting to give you a final score. On your interview panel, so along with these 2 interviewers who score you, there is another layperson, I think, who the camera is basically turned off, and they're just there for quality control and to ensure that the interview is fair and it's at the same kind of level for all the candidates. And there might be an admin person who's basically also the timekeeper, so they will say the time throughout your interview, so like 2 minutes remaining, 30 seconds remaining, things like that. So yeah. And this on the right hand side is what each mark means. So 5 is excellent, which is at the level of an IMT. Next. Yeah, preparation. So I used a bit of combination of all of these methods. I did not do any interview courses, to be honest, but I'd recommend practicing with a webcam or a mirror because you're going to do this online, so it's good to do with a webcam. I think practicing with a colleague was really helpful for me. So I did about 3 or 4 sessions with one of my IMT colleagues, and I think it was the most useful thing for my interview because we did go through a lot of stations while doing that. I did the medical interview book is very good, and I'd highly recommend that. I did not go through it end to end, but yeah, it definitely helped with quite a few questions. Yeah. What are your thoughts, Chantal?
Yeah, I would absolutely agree. I also used that medical interviews book. I definitely practiced with a friend who was also applying the same cycle as me, who also had an interview. I didn't take any interview courses either, but essentially we just ran through a bunch of clinical scenarios. There's a bunch of online resources that have kind of sample clinical scenarios that you can pay for. I know MediBuddy has one. I think PassMed and PassTest might have one as well. Lots and lots of online resources that you can source some scenarios. But the medical interviews book is very good for a lot of the communication situations that they can give you in your kind of ethical stations as well. I suppose with regards to your 2-minute personal statement, it's just good to practice it. I had a couple of friends just read over my 2-minute personal statement and make sure that, it actually makes sense and that it covers all of the relevant things that make you a suitable IMT. And then I guess the last thing to talk about is, yes, because it's virtual, it's actually very, very common for people to just not test their setup beforehand. I've spoken to a lot of consultants who've been in interviews, and they were saying, a lot of candidates showed up and, it's a messy background. The lighting is really poor. You can't really see their face. They've got like very bad sound or very bad connection. They're dressed a bit sloppily. All of these things kind of set you back, to be honest, because it's a virtual interview. So you should try and make the best first impression you can. Like I wore a button-up shirt and a blazer. I cleared the entire space behind me and I sat kind of at the window so there was good lighting. I locked my flatmate out so that it was completely quiet. You need to make sure, it's a conducive environment to an interview, and you need to look as professional as you can because this is their first impression of you. You can't handshake. you have to just look as professional as you can on a camera. So certainly test your setup before you start the interview.
Yeah, I think those are really good points. Just before my interview, my brother entered my room, and I was at his place when I did the interview, and that was really scary. Yeah, but they weren't online at that point, so yeah, it went all right.
Definitely. Yeah, I think one last point I suppose to make is that I know it's a 50-minute interview, which if it looks like it's very long, but actually it passes by really, really quickly. And for example, when I had my clinical scenario, I thought I really, really messed up on my clinical scenario. But the good thing is, you get a minute or two to read each vignette. So I was like, right, it's fine. I'll just take a breather, just read my ethical scenario. It'll be okay. And when I got my feedback, I actually ended up doing just fine on my clinical scenario. So I think sometimes they do really push you on some of the things. If they think you're heading in the right direction, they really do try and push you with quite intense questions sometimes. So even if you think you've messed up, try not to catastrophize. Just compartmentalize it, move on. You've still got 2 more stations to go. So make the most of your interview. So I guess I will talk about training now. So should we go to the next slide? So I guess I'll go quickly over my background. So I graduated from King's in 2020. I didn't have any publications. I didn't do any intercalated degrees. I was very focused on just passing medical school. The only thing I had that was notable was a 2-cycle QIP in Obs and Gynae, and we presented this as an e-poster at the International RCOG conference. So that was the only thing that I really had kind of points in. I then went straight into my F1 and F2 in Northwest Deanery in Royal Blackburn Hospital, which is a very, very busy DGH. My only medical job was gastro, and I didn't really think about doing medicine at all, actually. I initially thought I wanted to do obs and gynae or peds, and I had both of those rotations in my F2 year. I did my neonates rotation, absolutely hated it. Wrote off peds, did obs and gynae. I didn't like obstetrics, but I found out I really liked gynae, the non-surgical bits of gynae. I liked the medical side of things. But I was still kind of like, no, maybe I can tough out obs and gynae. And I didn't have any research experience, and I didn't really have a huge amount on my portfolio. So I took a year out to work on my portfolio. I did a PG cert in med ed, and I did a MSc in pregnancy and reproductive health in my F3 year. And alongside this, I locumed kind of 2 days a week. And actually, I ended up locuming just in acute medicine. And while I was locuming in acute medicine, I quite realized that I actually really enjoyed acute medicine. I like being on the take. I like dealing with kind of sick, acutely unwell patients. And so I pivoted to looking at a career in GUM, which is via IMT. So I decided to take part 1. I passed my part 1. And then after my F3 year, I applied for IMT, and here we are. So now I'm T2 in KSS. I've passed my part 2, and I'm hopefully going to take PACES next year. So next slide. I guess you don't need to know a huge amount of this for your interview, but it's good to think about if you're thinking of doing IMT. So it's worth knowing whether you want to do a group 1 or a group 2 specialty. So for those who are unfamiliar with this, a group 1 specialty means you do IMT 1 to 3, with IMT 3 being your kind of baby med reg year. And group 2 specialties being specialties that don't require you to do IMT 3 and don't require you to med reg during your higher specialty training. So that's things like dermatology. I think, what else? Could you go to the next slide? I can't remember what else is a group 2 specialty. Dermatology, hematology, oncology, these are all group 2 specialties. And things that are group 1 specialties are, your big ones like cardiology, respiratory. GUM is actually a group 1 specialty as well. It's worth thinking about whether you can tough out being a med reg for all years of your training, because that means you have to med reg as an IMT3, and you also have to med reg as ST4 to ST7 plus if you take years out. Some people don't want to med reg, and therefore that might push you to do a group 2 specialty. So it's worth having a think about. But I will say that some people I know who aren't going to do a group 2 specialty are still doing IMT3 because it's a good experience. So worth noting about the IMT 3 years, because it's a fairly new thing, is that IMT3s are technically a medical registrar. Some hospitals have IMT3 where they're paired with a senior registrar who's actually in higher specialty training, and you won't be alone on the take. However, other hospitals, smaller DGHs, the IMT3 works independently, and there's no supporting senior registrar. So at Maidstone and Tunbridge Wells, the IMT3 functions as an autonomous registrar. Overnight, they're the only registrar for medicine. So it kind of depends where you work. Next slide. So thinking about kind of day-to-day on IMT, unfortunately, there is a good amount of service provision in IMT, which you've probably heard before. This is the same wherever you work, but it can be variable, the amount of service provision you need to do, because it depends on the frequency of your on-calls. On the next slide, I'll show you, I've got a copy of my September rota. But to be honest, I really enjoy the on-calls. It can be busy. I think Maidstone and Tunbridge Wells is not a horribly busy hospital in terms of the take. I think KP can probably attest to that. And it's a very well-supported DGH to work in. And I think actually a lot of IMTs I've spoken to have preferred working in a DGH as an IMT, because you just get a lot more hands-on experience. I'm currently on the acute medical unit doing my IMT2. So we do an acute medical clinic 1 or 2 days a week. We get to do procedures in AEC. I deliberately picked the track that I've got because I thought it covered all of the big gen med specialties. So I've done IMT1 in respiratory, geriatrics, and cardiology. Everyone has to do a rotation in geriatrics, and everyone has to do a rotation in ITU. This is now a new mandatory thing. So my upcoming rotations will be ITU and endocrine. So along with AAU, acute medicine, I think that's a very good overview of the big medical specialties. And I'd already done gastros and F1. So I feel like if you're looking especially to be a med reg and you're applying for a group 1 specialty, it's worth having a think about getting a lot of the gen med specialties in instead of, I don't know, maybe going for a very niche subspecialty like oncology as one of your rotations, unless that's something you're interested in. In terms of your education in IMT, what is mandatory is that you have regional training days. These are usually virtual. It's once per month, and it's done by each deanery, usually a half day or a whole day, depending on the month. You also get local teaching. You're supposed to attend some ground rounds if you've got the time to do so. You get 30 days of study leave in total for your whole IMT 1 year, and then another 30 for your IMT 2 year. So that's 10 days per rotation if you're doing 4-month blocks like we do at Maidstone. The good thing about IMT is you can now use these as personal study days as well. So if you're prepping for PACES or prepping for part 2, you can take a couple of these days just to study. It's not like in foundation where you're not allowed to take personal study days. You can now use these as personal study days. You should also be allocated clinic days because you need to meet a minimum number of clinics. And you should also get self-development days, usually once a month, to do, careers work or work on QIP and stuff like that. I think my final slide, if you just go to the next slide, KP, is just an example of a rota. So the rota can be very heavy. You can see I've got 2 separate sets of nights and also a set of long day on calls, and that's on top of all of my ward days. So the hours are not insignificant. So it's worth thinking about if you're definitely set on IMT and you haven't taken any of your exams yet. I think the feedback that I've heard from my friends who didn't take any exams before starting IMT, so especially for part 1, it's very, very difficult to juggle a rota like that if you're working full time and trying to study for part 1, part 2, because it does require a lot of time. So if you're not applying this cycle or you think you can manage to sit it early in the year, it's worth thinking about sitting MRCP before you start IMT, because the rota can be very, very heavy and make it difficult to study. Right, I think that's it from us. I think we've definitely got some questions.
Thank you very much both for the presentation. That was great and really informative. We do have some questions in the chat. I'm just going to go through them one by one. Please feel free to add further questions if you have any. And please don't forget to fill in the feedback form at the end just to receive your certificates as well. So we'll start with the questions now. The first question is, are offers made based on portfolio plus interview scoring, or is it just interview scores?
It's just the interview scores, I believe. So your portfolio scores, where you fill in the self-assessment, is literally just for the shortlisting. Once you get an interview, you're all on even path, and then your offers are made based on your interview scores. I believe that's correct, isn't it, KP?
Yeah, that's true.
Yeah.
Okay.
I just wanted to say that on this year's portfolio, so on our first slide, I just read the statement. So the interviewers, while scoring you, will take into account your portfolio. So they do take that into account, but yeah, it's based on the interview scoring.
Thank you. The next question is, any advice for getting oral presentations at national and international meetings?
I think a good way to do that is to speak to consultants or registrars who are kind of big on publications or big on presentations. That's probably the easiest way to go about it, because they will know what conferences are coming up and whether or not they have a project lined up in mind that they wanted to present at that conference anyways. I think that's usually the easiest way to go about it. Yeah, I don't know if you have any ideas, KP.
I think that's true. I mean, I had a national presentation, oral and a poster as well, and I think it was all with the help of the consultant. So it is definitely you need a consultant to supervise you, speak to you, and they will guide you on making a poster. My consultant, he reviewed my poster multiple times before sending it over, so that was very, very helpful. And you could do poster presentations for you present the case report work, poster for QUIP, audit, anything like that. You can get a poster presentation.
Okay, thank you. The next question is it possible to clarify about MRCP, since they saw an 8-point scoring for it in 2025? Is it MRCP part 1 or all parts?
So I think that's for higher specialty training. MRCP doesn't count for IMT training. So you can say in your interview, like in your 2-minute presentation, I've already passed part 1 and part 2. Like, I'm very proactive. I'm really dedicated to internal medicine. But it doesn't count for any points as such.
Okay, thank you. And I think you already answered the next question, which is if the portfolio score still matters once shortlisted for an interview. Is that the score is based on your interview alone once you get that. The next question is, can you give us an example of clinical and ethical scenarios?
I think, did we have some on our slides?
Yeah.
We can bring that up, I guess. So I think in terms of clinical scenarios, the best way to practice for it is just to think about any kind of acutely deteriorating patients. So people that you would see in resus, people you would see on the take, and just practice kind of A to E scenarios for them. Obviously, we're not allowed to say which scenarios we had on our interview, but just think about what's an acutely unwell patient. So people with a CAP, people with pyelonephritis, delirious patients. And it's not just about the A to E scenario, it's about the additional considerations. So for example, someone who's really, really poorly and very, very frail, it's not just about the medical management, it's about the communication to the family, it's about having DNAR discussions and ceiling of care discussions. And I think that's probably the important things to say about clinical scenarios. I don't know if you've got anything to add, KP.
I think one thing I noticed was on medical take, if you're doing medicine, on medical take, you generally have quite a bit of information about the patient and have like a plan in place. Whereas these scenarios sometimes can be more of like the patient is presenting an ED and you don't have a lot of information. You just have like 1 or 2 lines of the patient. And then when you go through A to E, you get more information, like the blood results and imaging and stuff like that. So,
yeah, I think after you finish your assessment, they give you additional information. So they might give you some imaging or investigation results, and then they ask you to interpret that as well, and kind of give some differential diagnosis and additional management. And you're allowed to change your answer. So if you see the results and say, actually, this now looks more like, you know, a different condition, you just need to be able to justify why you're going down that line. Yeah, they might just continue to push you on the diagnosis. If you are sure of the diagnosis and you feel confident in it, don't necessarily let their questions sway you, because sometimes they just keep pushing because they want to see that you know you're confident in your assessment and in your abilities. So I know for my clinical scenario, they really, really pushed me and almost tried to get me to change my answer, even though I was fairly certain with my answer. And that's why I felt a bit nervous after my clinical scenario. But actually, it turned out I gave the right answer. So just stick to your guns. Make sure you've practiced, and don't let kind of their leading questions fool you sometimes.
That's lovely. Thank you very much. The next question is, what's SCE/KBA?
SCE.
I don't know. Did we use that somewhere?
Don't remember now.
Would you like to clarify in the chat, please, what you mean by those abbreviations, if you saw them on any of the slides? And then we'll move on to the next question and come back to this. Thank you. The next question is if there's any suggestions for less than full-time training applications, any caveats to be mindful of it.
I don't know, actually. I don't really know any less than full-time trainees. I don't know if KP, you can share that.
I think in our IMT1 year this year, we do have quite a few trainees who are less than full time, so 2 or 3. To be honest, I don't think it makes any difference whether you can apply. You can tick it on your application that you want to go less than full time, and it does not make any difference to your scoring or whether you'll get the job or not. It just does not make any difference. And I think even the interviewers don't know what you have selected on your application. It does not matter. Only thing is you will right from the beginning, you'll go less than full time if you take that, and if you don't take that, you still have the option to go less than full time, say in the second rotation. Sometimes they delay it by a rotation or so if they don't have the adequate staffing, but I cannot think of any.
Yeah, you can change your mind. So if you do IMT1 at full time and you decide it's too much, you can always drop to less than full time in IMT2 or, you know, halfway through IMT1. That's not a problem. It's important to note that actually IMT is technically competency based. So if you go 80% and you meet all of your portfolio requirements, your take requirements, you can technically still finish in the same amount of time, but this is very, very deanery dependent. So some places don't technically stick to this. So you just have to be careful depending on where you're applying for. As long as you don't mind potentially having to extend your training slightly, then less than full time is a very good option.
Okay, thank you for that. And in the meantime, we got a clarification for those abbreviations, SC and KBA. They said that it was in a IMT timetable screenshot.
Ooh.
Oh, okay. Okay.
Where was that?
Timetable, timeline.
Timeline?
Sorry, looks like one.
No, it's in the timetable apparently.
Yeah, it might have been on the snapshot of your rota.
Was it on my rota?
Could be, I think.
Oh no, it was on the timeline apparently.
Timeline, did they say?
Okay.
Where did we put SC KBA?
Cannot. Where is SC? Can you see it? I did.
I don't see it.
Is it possible? I can't see SCE KBA. Is it here? No, very sorry. Don't know.
Thanks again. We can come back at the end if we get a further clarification.
Sure.
And we'll move on to the next question. How much score do you think we need to get shortlisted for an interview?
It is there's documents on the IMT application page. It tells you what the shortlist score was to meet minimum for interview. I can't remember what it was in last year.
So if you go to the document library on the IMT recruitment page, it should have the latest scores available there. It has lots of useful documents. So I'm just taking it back to the last slide where there's a link to it. So that's the one. So if you just go to Google IMT recruitment, and there's a document library section on there, you can find that information there.
Oh, I think I know where the SCE is. If you go back a couple slides to the overview of Group 1 and Group 2 specialties, I think I saw it there. Yeah, SCE is the specialty exams. So that's when you take your specialty exams. It's not really relevant for your IMT, don't worry.
Great.
Thank you. The next question is, how easy is it to get an F3 job if preferred to take a break from training work on portfolio after F2? Heard recently junior clinical fellow positions are quite limited.
I think it depends where you work and where you're if you want to move, if there's availability at the current trust that you're at. It's very, very variable, to be honest. It's kind of hard to say. I know locum posts are difficult to come by at times because they're trying to hire more JCFs or F3s in kind of a long-term rota pattern instead of paying for locums. So it just kind of depends. It's hard. It's a bit hard to answer that one, I'm afraid, because it will depend where you are and where you're willing to work.
I think I've heard the same thing, that locums are drying up, which basically means they have to fill these posts somehow. So I personally think there will be more F3 jobs if they don't want locums. So yeah, cheaper for the trust.
Thank you. Is it possible to apply for higher specialty training via IMT if you have all the necessary requirements?
Yeah, so you can apply for higher specialty training in IMT2 if you're applying for a Group 2 specialty. If you are applying for a Group 1 specialty, you can only apply during IMT3 because you need to complete your IMT3 med-reg year before you're allowed to go into a Group 1 specialty.
Thank you. Our next question is, are all your rotations in one hospital, or do you have to keep moving, especially after IMT3 or when you get into GUM?
It depends where you work. So I deliberately picked the track I'm at because I stay at Maidstone all 3 years of my IMT training. But other places you move around every 4 or 6 months. It's very possible. So you have to be very, very careful when you're picking through that spreadsheet after your interview about all the jobs, because it will tell you if you're going to have to move hospitals every couple of months, because that makes things difficult, obviously, if you have to move house, move cities or whatever it is. Usually you will stay in kind of the same region for each year, usually, but that's not a guarantee. So if location is something that really, really matters to you, be very careful when you're ranking your jobs.
I've got one rotation at Tunbridge Wells, so it's a different hospital. So yeah, but there are some. This is doable. This is like a half an hour, 40-minute drive. But there are definitely some rotations that I saw while ranking the post. So for example, there was one in Newcastle, and then 1 year is in Carlisle. So it's literally like East Coast and West Coast. So you have to move there. You cannot drive. So yeah, there's something to be careful about.
Thank you both. And I think the last question is there 2 cycles for IMT applications?
I think it depends if there's any jobs or vacancies left over. It's not always guaranteed, I believe, if there's, because the big intake is this current upcoming one. So I think it depends whether or not there's any leftover jobs, which often I think the answer is no.
I think I don't know how it works, but I know somebody who started at my previous trust in February last year, but I think they're just one-off posts or something.
Yeah, they're very, very infrequent, I think.
Yeah.
So I wouldn't bank on getting a group or like a second cycle. If you're going to apply, commit to this cycle.
Yeah, this cycle. But I also think that the way that second start works is you still apply in August for the August round, and then if you have not accepted any training program and you were ranked at some point and a new post becomes available sometime later, you get that. But I'm not sure. I'm not sure about this. But yeah, there's just one.
Thank you. And one more question came up in the chat. What's the difference between round 1 and round 2 invites?
There's just round 1 for IMT because all the posts are getting filled. So I don't think they're doing any round 2s at this stage.
Okay. Thank you very much both for your time and for your participation, and thank you everyone for joining us and asking your questions in the chat. It was really great. Please don't forget to fill in the feedback form in order to get your certificates. And thank you very much for your time. Have a great night.